When you see a lot of patients with coronary artery disease, after some time you will realize that the patterns of involvement repeat themselves over and over again. In this chapter, I want to show you some typical patterns and also which vessel territories are involved and what the importance is for remodeling, for example. In addition, I want to discuss also the relevance of echocardiography in the setting of coronary artery disease and how good echo actually is. So how good is echocardiography in the specific regions? Well, actually quite good for the LAD territory with a sensitivity of 90%, followed by the RCA territory and the region which is supplied by the circumflex artery. So the weakness is this region here, in other words, the lateral and posterolateral myocardial segments. I now want to go step by step and show you some typical patterns of infarcts. Of course, there's always some overlap between the different patterns, but you will recognize if you perform echocardiography that they repeat each other over and over. First, let's take a look at the supraapical infarct. It is associated with an LAD problem, but the occlusion does not necessarily have to be distal or mid. It can also be proximal if reperfusion was achieved quite quickly. It involves only a few segments, but these segments can also be aneurysmatic, so you might see supraapical aneurysms. The residual contractile function is okay, so the risk for remodeling is fairly low. Here's such an example. If you look at the three-chamber view, it's very difficult to actually see that there is a wall motion abnormality here, but if you tilt the transducer more medially and point towards the apex, or more laterally and also point towards the apex, you see that there is an infarct here, but you also see that there's even a thrombus inside. So these infarcts are sometimes very difficult to see, and residual function is usually normal or only mildly impaired. The next form of infarct is the distal septal infarct. Here you have the involvement only of the distal septum. Again, the LAD is involved. Again, it can be the distal, the mid, or the proximal LAD. And similar to the example I showed you before, the risk of remodeling is also very low because the residual function is still okay. Here is an example. We see that there's a small region of hypokinesia here in the distal septum, and the residual function here is okay. Again, small region, distal septum. If you look at the short axis view, you can see that the mid segments are all normal in contractility. So these infarcts too are fairly difficult to see at times. The next form is the apical infarct, as I would like to call it. These infarcts are usually due to at least the proximal or the mid LAD, so it's very rarely only the distal LAD which causes these infarcts because they're actually larger than the infarcts I showed you before. Usually these infarcts are, however, after the first septal branch, and these patients already have a certain risk of remodeling, which depends on other factors as well. For example, the presence of mitral regurgitation or the degree of afterload. If you look at the regional wall motion abnormalities in these patients, you can see that the infarct involves the distal septum, distal lateral, often infraapical, and the anterior septum in here, and even the distal lateral or posterolateral region. So more segments are involved. Then we have the large anteroseptal infarct, which is even larger. It is caused by an LAD occlusion which lies very proximal before the first septal branch. The risk of remodeling is very high in these patients. You almost always see some form of remodeling. And we have involvement of the entire apex, including mid portions of the anterior septum, sometimes even further down, also involving the inferior septum. Then we have involvement also of the mid-anterior segment, sometimes even of the mid-inferior segment, especially if the LAD goes all around the apex. And we have involvement of large portions of the anterior septum, as already mentioned, sometimes even further down all the way to the basal septum. Here's such an example of an acute infarct which was caused by a proximal LAD occlusion, and we see that we have wall motion abnormalities which involve the mid-anterior septum, the entire apex, all the way around to the mid-level lateral, far down into the inferior region. Here's the hinge point. In the two-chamber view, you see the mid-anterior wall is also involved, and we see that almost the entire anterior septum is involved. So this patient has a very large infarct, and if the patient does not have a reopened vessel, I'm certain he will have a large scar and a very high risk for remodeling. Here another example of a large anteroseptal infarct. The only difference is that this patient had his infarct 6 months previously, and you already have a remodeled left ventricle. You can see involvement of large parts of the septum all the way to the mid-level. The apex is involved. We have involvement of the inferior segments all the way to the mid-level, and also the anterior septum. Now let's turn to the inferior infarcts, and first to the small basal inferior infarct. It's caused by occlusion of the right coronary artery, and it's difficult to find and interpret simply because it's located very close to the membranous part of the interventricular septum, which is usually thinner. You can also see it in the two-chamber view in the basal inferior region here. The risk of remodeling in this form of infarct is usually very low. Now let's look at a typical example of a small basal inferior infarct. This is a patient who had a subacute infarct a few days old, and you can see there is a wall motion abnormality here in the basal part. You have to look very closely to really detect this wall motion abnormality, and you can also see the abnormality here in the basal part in the two-chamber view. This is even nicer to see here in a zoom view, where you can see that there is no thickening of the wall. The next example of an inferior infarct is one which is slightly larger than the one you saw previously. It's also caused by occlusion of the right coronary artery, and since it's still very small, in general it also has a very low risk of remodeling. We have the basal inferior septum and the basal and mid-inferior segments involved. So we have more involvement of the inferior wall and sometimes also a bit more involvement of the inferior septum. This is the corresponding example. I want you to take a look at the two-chamber view first, and you can see the wall motion abnormality here in the basal, mid, and distal inferior wall. And you can also see there is very echogenic myocardium, which means there already is some form of scarring here. If you look at the four-chamber view, the wall motion abnormality is here, basal inferior septum, and also ranging into the mid-inferior septum. No wall motion abnormality here in the lateral wall, and also no wall motion abnormality here in the three-chamber view. So this segment and these segments are affected. The next, even larger form of infarct, inferior infarct, is the one that ranges all the way to the posterior region. So we have involvement of the basal inferior septum, the inferior septum, just as we saw previously, but now also all the way into the posterolateral region. These infarcts are caused by fairly large right coronary arteries or by a very large circumflex artery, which also supplies the inferior wall. The risk of remodeling is now increased. It's at least moderate. The echocardiogram shows the wall motion abnormality here, basal inferior wall, basal and parts of the mid-inferior wall, and basal and mid-posterolateral wall. Remember, you can also see these wall motion abnormalities in the two-chamber view, and you can often very nicely see the extension from the inferior to the posterolateral wall in such views. The next infarct is the posterolateral infarct. It's usually caused by a circumflex infarct, but can also be caused by infarcts of the posterolateral system of the right coronary artery. We now have involvement of the posterolateral wall and the lateral wall, and not the inferior or the inferior septum. The risk of remodeling in this type of infarct is usually fairly low. To really get a good view of the lateral wall, you have to rotate the transducer clockwise from the 4-chamber view and maybe angulate the transducer a bit so you get a better appreciation of the lateral wall here, how it extends into the posterolateral wall. And you see clearly a very thin echogenic and akinetic wall, basal and mid. So this is lateral, and this is the posterolateral extension of this infarct, again akinetic, echogenic. You see this very nicely often in short axis views, as I mentioned previously. So you see the infarct extending here into this region here. So this is the posterolateral lateral wall. RCA and circumflex infarcts can also be fairly large. They can extend from the inferior wall to the inferior septum to the lateral wall all the way to the posterolateral wall. Usually we have a very large dominant right coronary artery or circumflex coronary artery. Usually there is some form of proximal involvement, not just a branch, and the risk of remodeling in these infarcts is fairly high. Here is such an example of a very large infero-posterolateral infarct. We have involvement of the lateral wall here. You can see this very nicely. The basal and mid portion, the entire inferior wall, basal, mid, and distal, and at least the basal and mid posterolateral wall. Finally, let's talk about the lateral infarct. The lateral infarct is usually caused by an occlusion of the circumflex or the LAD, for example, a diagonal branch, and it is sometimes very difficult to see because this region is very difficult to interpret at times. Since the infarct is in general very small, the risk of remodeling is fairly low. This is a very nice example. You see not only a wall motion abnormality here in the lateral wall, but also a small aneurysm. This was caused by a circumflex infarct. Now it's time to look at patients with regional wall motion abnormalities, and keep in mind, don't always stick to the standard views, but also use abnormal views. Let's take a look at a patient with coronary artery disease, and let's look at his parasternal long axis view. Now the parasternal long axis view has a disadvantage that we do not see the apical segments, but we can appreciate wall motion abnormalities in this view as well. First of all, let's look at which segments we can see. This is the posterolateral wall, while this is the septum. Again, we have the basal segments here, and we have the mid segments here. We do not see the apical segments, which would be somewhere here. It's clearly apparent that there is a wall motion abnormality here in the mid-anterior septum. So even if we don't see the apical segments, we can appreciate that this patient must have some scarring or some form of myocardial infarction in the region of the LAD territory. Next, we'll take a look at the apical views of this patient, and keep in mind, always correlate the parasternal with the apical views. Let's take a look at the apical views. This is the 4-chamber view, and let's focus on the various segments, and you will appreciate that the distal septum here and the apex has a wall motion abnormality. This part of the septum still has normal wall thickness but seems to contract hypercontractile, while this portion here is scarred. There's a thin wall, and the scar reaches all the way to the distal lateral portion and shows some degree of dyskinetic motion. You can also appreciate that in the 2-chamber view, we see that there is a scar here in the apex, while the remaining part of the inferior wall contracts normally. This would be the hinge point here. You see you have normal myocardium and scarred myocardium, and the motion is abruptly discontinued here, and the anterior wall contracts normally. Let's take a look at the apical 3-chamber view. Very similar picture. The apex is involved. We have a thin wall here. We have akinesia, dyskinesia here. and normal contraction of the posterolateral wall and of the remaining portions of the anterior septum. So, in conclusion, this is a patient who has a fairly small myocardial infarction, which is located in the apex, which has a scar here in the apex and probably some form of non-transmural myocardial infarction, probably in the septum, but with good remaining left ventricular function, and no other portions of the myocardium show wall motion abnormalities. Okay, so this was an example of an anterior infarct. Now we'll turn to an inferior infarct. We now have a patient who is 69 years old and in whom we found a scar in the inferior wall, which was found by chance. The patient never had any complaints and he does not remember of having an infarct. But however, on the other hand, the patient is diabetic. So let's take a look at his echo. This is the parasternal long axis view, and what we appreciate is that the patient must also have other risk factors, hypertension, simply because there's left ventricular hypertrophy, there's also aortic valve stenosis, and we also see degenerative changes of the mitral valve apparatus. But what we also see immediately is that there's a scar here in the posterior wall. The wall is thin, does not contract normally, and there's also more echogenicity within the posterior wall. The remaining portions, as far as we can see them in this view, seem to be normal. So let's now go to the short axis view. And in the short axis view, again, we can correlate these wall motion abnormalities. We have a scar here in this region, inferior, posterior, basal inferior septum. So this is the region that we would find the scar. What is also interesting to see is that we have an echo-dense area within the posterior region here, which really means that there is fibrosis here. Let's now go to the apical views, which usually show us even more. Usually gives us more information about the regional wall motion abnormality. And in the four-chamber view, we see that there's fairly normal contraction here in the lateral wall here, apex septum, but the basal inferior septum does seem to have a problem. You can notice that if you tilt the transducer downwards, you see the coronary sinus here, so we're in the coronary sinus view. So these are the basal inferior portions of the interventricular septum, and there is a wall motion abnormality here. However, the septum does still have a normal thickness. Let's go to the two-chamber view, and here you will immediately appreciate that there is akinesis here. Wall motion still seems to be, wall thickness seems to be present here in at least portions of the inferior wall, and dense echogenicity here. I'll just tilt the transducer to all the different regions of the inferior wall. You see the scar goes all the way up to the mid portion of the inferior wall. And then I will turn the transducer more towards the posterolateral region. And again, you can see there's a scar here. You always have to watch out. The papillary muscle obviously is still moving, but the scar seems to go all the way up to here. So this is all scar and akinesis. And there also seems to be some degree of dyskinesia of the posterolateral wall. And to really look at the entire myocardial function and the entire regional wall motion abnormalities, it's always good to also look at the view where you rotate the transducer from the four-chamber view towards clockwise towards the lateral wall here. So again, you see regional wall motion abnormalities here all the way to the mid-lateral wall, which means that there is an infero-posterolateral infarct. Very important is always to look at the other regions of the myocardium very closely. We saw that the lateral wall, at least in this part, seems to be contracting okay, and that the apex seems to be doing okay. But if I move the transducer a bit more towards the right shoulder, you can see that there is some degree of wall motion abnormality also present in the septum, in the very distal portions of the septum. So right here. So this means that the patient could also have multivessel disease, which also involves, for example, the LAD. And we know from the angiogram that the patient indeed has a three-vessel disease. He has an occluded right coronary artery. He has a critical obstruction in the circumflex artery and also subtotal obstruction in the mid-LAD. So altogether, if we now put all this information together to determine what the global function is, we would probably quantify the global function as mild to moderately reduced, considering the extent of the scar. And the big question will now be, if we revascularize this patient, which portions of the myocardium will then still recover? So I'm sure you'll recognize these patterns in patients with infarcts. However, keep in mind that these patterns do not necessarily mean you cannot see other forms or forms of involvement, simply because some patients have more than one infarct, an old infarct and a new infarct, for example. And, of course, contractility can change over time. For example, myocardium can recover after an infarct.